Right, hi guys, welcome. So what Reed and I have decided we're going to set up is this YouTube channel, so to help you guys prepare for all the things that we've got to sign off. So pharmacology is our next one coming up, and so we're obviously going to start with pharmacology. Now, firstly, I don't want everyone to panic. I'm putting a lot of effort into this so that we can make it as easy as possible and that you can learn as much as possible, because ultimately the more you learn, the better it is going to be for you. And it is especially important for you guys in Corryong because at times you will respond on your own. Pharmacology saves your butt if you know your drug protocols inside out, because if you're signed off on this as far as the service is concerned, you're competent. So if you make an error and you give a contraindicated drug, there will be an inquiry, etc., which is why we want to make you guys as safe as possible in this. It's really an easy topic, it's just about spending the time on it. So let's get cracking into it. So pharmacology for the Corryong ACOs. Alright, we're going to go through each of the drugs. So I'd suggest to grab a notebook, pause this if you haven't got a notebook with you. Grab a notebook, grab your drug protocols chart as well, like that little book you guys have got. And then we're going to go through each of the drug charts and pretty much explain why certain things are the way they are. Aspirin. Firstly, just simply the indication for aspirin, it's just chest pain or discomfort, cardiac chest pain or discomfort. Now, the reasoning for giving aspirin for cardiac chest pain or discomfort is because we want to stop platelet aggregation occurring. Now, there's some fancy words which just in essence means we want to stop the platelets that's in your blood from clotting. Because what we're suspecting is happening in cardiac chest pain or discomfort is that there is a clot forming somewhere in the heart. So if there's a way we can stop this process, we have to, and that is what aspirin does. Aspirin assists us to stop this clot from increasing in size, potentially blocking the artery completely. So in the presence of cardiac chest pain or cardiac sounding chest pain, aspirin is indicated. Now, I know normal everyday life we tend to use it for headaches and anti-inflammatories and fevers and stuff like that, but as for your AV protocols, you are only indicated to give aspirin for chest pain, cardiac chest pain or discomfort, not for any other reason. Moving on to its contraindications. So on each slide, before I move on, you'll see there is a little reason tab. This is just for you guys to write as I'm talking, any notes you want to remember. If you want anything more in the video, just go back and go over it again. So it's all here for you guys to write in your own words what the reason is that we give each drug. Alrighty, the contraindications of aspirin. So firstly, hypersensitivity to aspirin or salicylates. Chest pain associated with psychostimulant overdose if the systolic blood pressure is greater than 160. 3. Actively bleeding peptic ulcers. 4. Bleeding disorders. 5. Suspected aortic aneurysm. And scabs is the one we are going to use to remember all these things. So everyone has different acronyms. This is the one I use. If you like it, you can use it. Otherwise, use the one of your own. So you see all the letters that are highlighted in red in the contraindications. That's what scabs stand for. So going through these precautions and why they are there. So like I said before, aspirin interferes with the clotting factors in your blood. So aspirin stops the clotting from happening. Now this is going to be a little bit problematic with people who have any bleeding disorders or any problems with bleeding. So looking at those bottom two, so actively bleeding peptic ulcers and suspected aortic aneurysm as well as bleeding disorders. When you think about these three, if the person already has bleeding disorders or has peptic ulcers that are bleeding in their stomach, you don't want to make them bleed more, and that's why this is contraindicated. And with an aneurysm, they're already at risk and we need all the clotting factors they've got to stop them bleeding out, and that's why we don't give them aspirin, because you're just going to stop any ability they have to stop the bleeding from the inside. So an aneurysm, just to give you a little bit more so you understand why, an aneurysm is in the aorta wall. So the aorta is that really big artery that sits in your tummy and feeds all the blood back to the heart. So a tear happens in that little artery and the blood starts to pool in the lining of that artery. Now this is absolutely life-threatening. If that little tear where the blood's pooling bursts, you'll bleed out in a matter of minutes. What stops it happening is any potential clotting. It doesn't necessarily stop the actual process. It's probably still going to happen, but it does give you some chance. So that's why it is a specific contraindication. But you're not expected to know how to diagnose this, and we will talk on the night about something specifically around it so it clears it up for you. Bleeding disorders, like I said, should make pretty good sense, because if persons already have trouble bleeding, so if they cut themselves, they don't stop, they already don't have any clotting factors. So if you now give them aspirin, they're not going to have any at all, so they're just going to keep bleeding. Now, when you're looking at the second one, so chest pain associated with a psychostimulant overdose and a systolic blood pressure of greater than 160, so the reason it's contraindicated is because in these patients, if they have chest pain or discomfort, it is most likely due to the fact that their heart rate is going too fast, not because of a cardiac origin. So we're not suspecting a clot's necessarily forming there, and that's why they've contraindicated it. It's not necessary for these patients, and their heart's already working hard enough. And again, we don't want to interfere with the clotting factors where we can. And then the obvious last one is just the top one, which is hypersensitivity to aspirin. And if someone is allergic, they will tell you. That's why we always ask allergies in the clinical approach. So if you want to use SCABS as your acronym to remember all these contraindications, go for it. Otherwise, just use one you'd like to use. Right, moving on to precautions. So first one, asthma, history of peptic ulcers, and patients on anticoagulants such as warfarin. And the acronym that we're going to use to remember these, or that I use, is AHP. It kind of sounds like BHP, and that's why it makes sense in my head. But like I said, if you've got another one, or if you just remember these, that's fine. The acronyms I've just put in for people who like to use acronyms. Now, going through these precautions to give you a little bit of an idea why they are precautionary and not contraindicated. So starting off with asthma. Certain patients that have asthma actually know that their asthma is triggered by aspirin, and that is why they don't take it, and it's also why we shouldn't be administering it. So they'll usually tell you. Or if you notice that there is asthma in their history, ask them if they have taken aspirin in the past and if they're okay with it. So aspirin is purely a precautionary one. Sometimes the risk needs to outweigh the benefit, but that's not a call you'll often have to make. So this is more just to give you a little bit of background. So if they have asthma, just ask. Maybe it'll be a good idea just to ask if they have set off any reactions in the past by taking aspirin. Now, history of a peptic ulcer is purely there for you to work out whether the ulcer is active or not. So if people have actively bleeding peptic ulcers, aspirin is contraindicated. If they only have a history of it, but they don't currently have an active one, you can still give it. It's only a precaution. And the reason the precautions are there is just so you make sure you ask enough questions to make sure that aspirin isn't actually contraindicated for them. And then patients on anticoagulants, so that's things like warfarin, even just aspirin as well. And there's multiple other ones you will come across with new names and things emerging, but ultimately if they're on an anticoagulant, so usually patients with atrial fibrillation, or if they've had strokes or stuff in the past, will be on an anticoagulant of some sorts. So anticoagulant in essence just means they're taking something to stop their blood clotting because of whatever reason they need it for. And again, this is precautionary. So if we are suspecting that a patient is suffering cardiac chest pain and they're also on warfarin, it's just a precaution. It's not a contraindication. It's just be wary of the fact that they are already on an anticoagulant. Again, it doesn't really change your management. Just know and take into account that you are messing with their clotting factors. So potentially it can do them some harm, but like I said before, with your cardiac chest pain, the risk is always going to outweigh the benefit. So if they're only on warfarin daily with atrial fibrillation and they're now presenting with cardiac chest pain, you'd still give it to them. So it's more there, like I said, as a precaution. Think about it, ask some more questions if you are unsure, but otherwise it is fine to give. And a precaution does not mean it's contraindicated. It just means maybe ask a few more questions to make sure that you are happy to give it. 1, 2, the side effects of aspirin. So, side effects: heartburn, increase in bleeding time, gastrointestinal bleeding, hypersensitivity reactions, and nausea. The acronym I have for this is HIGH-N. Kind of sounds like some street drug or something. Again, if you have your own one, great, use that one. This is only the one I use to remember it all. And like I said, the highlighted letters corresponds to the specific dot point. Now, going through them, the top, well, not really, the top two and the last one, nausea. So heartburn, increased bleeding time, and nausea, as well as gastrointestinal bleeding. That's all really just to do with aspirin itself and how it works. So it irritates some people's stomach linings very, very quickly, and they're quite sensitive to it. And that's why you see especially nausea, heartburn, and at worst case you see some gastrointestinal bleeding But again, if we want it, if it's risk and benefit, you know, if people refuse aspirin, they can refuse. But if you're just doing it because it can, withholding it because it can potentially cause something, don't worry about that so much. That's thinking about it too much. These are just the side effects for you to be aware of. So if the patient starts to complain, you know, of really bad heartburn halfway to hospital after you've given aspirin, you are aware that it's a side effect, and it helps you not to panic because you know that as a side effect that's okay, you can deal with that, that's fine. And you can also reassure the patient that, look, it's potentially just a side effect of the aspirin, but it's okay. We'd rather give you the aspirin to make sure we're looking after your heart, if that makes sense to you guys. So these ones are really just keep an eye on them so you know that they can potentially come. Just the last one to touch on is hypersensitivity reactions with it. Now, hypersensitivity reactions, particularly isolated to aspirin, can be things like allergic reactions. So you can potentially see something like an anaphylaxis or rashes or swelling in the face. So you might see a reaction quite similar to an anaphylactic reaction. And with asthmatics, it can also kick them off and set off an asthma reaction for them. So in your special notes, you are not to administer aspirin for any condition other than chest pain or discomfort of a cardiac nature. So it makes it quite simple. Don't give them aspirin if they've got a headache. Don't give them aspirin if they've just got a little bit of a fever. All we give it for, with you guys as first responders, is for chest pain or discomfort of a cardiac nature. All right, second. So indications for adrenaline. Anaphylaxis or a severe allergic reaction. Now, the reasoning behind it, we went through this all, especially when we did anaphylaxis. I'm not going to spend a heck of a lot of time on this. It is specifically for you guys only for anaphylaxis or a severe allergic reaction. And as you know, adrenaline is the drug that saves their lives with the anaphylaxis because it does all the actions of adrenaline. So it causes vasoconstriction and causes bronchodilation, and most importantly, it stops the mast cells degranulating. So in essence, you stop the anaphylaxis reaction. If any of these words doesn't make sense to you guys or it's confused you, don't worry, we do cover it in anaphylaxis, and if you've got questions on training night, we'll go through it. But you give adrenaline because it is the only life-saving drug that these people need who are currently in anaphylactic shock or are having a severe allergic reaction. Right, moving on to the contraindications. Super easy. Nil of the significance to the indication. So in other words, you do not give this unless they are having a severe allergic reaction or they're anaphylactic. The reasoning is simple. That's what you're indicated for. There's also multiple side effects for adrenaline you don't necessarily want. And look, let's not make things complicated when they don't need to be. So adrenaline is a safe drug. In saying that, it's not something you have to worry about. It naturally occurs in people's bodies anyway and is very safe to administer in the correct situations. And for you guys, it'll be anaphylaxis or severe allergic reactions. Right, moving on to the precautions. Again, super duper easy for adrenaline. Nil of significance to the above indication, i.e. if they're not anaphylactic or if they don't have a severe allergic reaction, do not give it. Right, the side effects of adrenaline. So we've got tachycardia, we've got hypertension, dilated pupils, and feelings of anxiety or palpitations. I just realised I forgot to highlight the F in red for you guys, but I'm sure you can work it out. So the acronym I had, sorry Tash, I thought I'd use your name because it just seemed to work well. So Tash had fish for dinner. So the T, H, D and F are highlighting all your side effects of tachycardia, hypertension, dilated pupils, and feelings of anxiety and palpitations. Now, these effects mainly occur because of what adrenaline does normally. So adrenaline, for a start, causes an increase in heart rate, so you get, i.e. your tachycardia. Another action of adrenaline is it constricts all your blood vessels, so more blood goes back to the heart, so you have a higher blood pressure, i.e. your hypertension. The dilated pupils are just a natural reaction of adrenaline. So when you think of your flight response, adrenaline kicks in that time. So your pupils dilate. It's your body's survival response to allow itself to take in as much stimulus as possible to save you. So the dilated pupils is just a natural reaction that your body has to it. The feelings of anxiety or palpitations or even uncomfortable just tends to happen with people because they're a little bit relaxed, but their body's just been kicked into a fight-flight response. So all of a sudden, they've got a heightened sense of alert. you know, they're ready to fight or they're ready to run. So the anxiety and palpitations is just a normal feeling that's going to occur. It is recommended that you warn your patients that this might occur when you're giving adrenaline, because it tends to freak them out a little bit if you didn't warn them before it happens. All right, let's motor along. Glucagon. Indications for glucagon. Diabetic hypoglycemia with an altered BGL of less than 4 and altered conscious state. Now, Ambulance Victoria has had a BGL of 4 as their limit. Some hospitals or other health industries might have other levels, but for Ambulance Victoria it is less than 4. So if you take their sugars and you find it is less than 4, then glucagon is one of the treatments that you can give to them. So glucagon particularly we tend to give to people who are unable to follow commands, because you guys only have glucagon or glucose paste as an option. So glucagon is your only option for patients who can't follow commands. You can't put something in their mouth if they can't swallow it. They're just going to end up choking on it. So glucagon is your option for them. Moving on to contraindications. Very easy one. Nil of significance to the indication. So if their sugar is not less than 4, you don't have to give anything to them naturally. Precautions, again, super easy, super fast. No significance to the indication. It is a very safe drug. It normally gets secreted in the body anyway, which is one of the reasons that it is so safe. Right, going through the side effects, just a couple. Nausea and vomiting, which is rare. Now, the reason nausea and vomiting can occur is because you've now put glucagon into their body. So glucagon's gone to the liver, say, hey, we need some sugar. The liver's converted your glycogen stores, which is when the liver stores your sugar, it converts your sugar to glycogen. It's converted the glycogen stores into the sugar that's needed and straight into your bloodstream. So now all of a sudden your blood glucose levels has skyrocketed because, well, you needed it, but your body might react a little bit badly to this, and hence why you see the nausea and vomiting. It is a rare one, and it is rare because of the fact that glucagon is a natural hormone that gets secreted by the pancreas. But just for your information, and that you need to know as well, if your patient starts having some nausea and vomiting after glucagon, you can reassure them, and you yourself can be reassured that it is a natural hormone, but they're just having some nausea and vomiting because they're quite. Now, going through to the next one, glucose paste. Now, like I said, you've got your two options, which is glucagon and glucose paste. Glucose paste is specifically for diabetic hypoglycemia, so sugars less than 4 and altered conscious state, but they're able to cooperate. So if your patient's sugars are less than 4, but they're still conscious enough to listen and to follow your commands, you get to go with the glucose paste. Contraindications, inability to swallow due to the altered conscious state. Now, like I said before, this is purely to protect them from choking and to make things worse. So if they can't swallow and they can't follow your commands, don't give it to them. Now, the precautions for glucose, again, very easy, nil of significance. It is not going to do them harm in any way. It is not a dangerous drug. It's only going to be dangerous if you let them choke on it. But otherwise, it is a very safe drug to use. Side effects of glucose paste, nausea and vomiting. So, sugar we eat on a daily basis, and it's not going to cause them any harm. It's unlikely that you're going to see nausea and vomiting though, but they might purely be because they're irritated. You've just given them a really high concentration of sugar. Their stomach might not like it, and that's why you might see some nausea and vomiting, but nothing to be overly concerned about. Sorry guys. Bob, go do something else. He's decided to come and help. Alright, going through and on to GTN. Indications. Very simple. 1, straightforward. Cardiac chest pain or discomfort. Now, GTN specifically, to give you a little bit of background about the drug. Fun fact, initially it was an explosive. And now then they realised because all the workers are working with it started fainting, something must be happening with this. And, well, what do you know? Next thing we're using it for cardiac chest pain. So how GTN works and what it does. So GTN, when we use it in cardiac chest pain, it dilates all your blood vessels. So all the pipes that were really small now in your body has now opened up. Now this happens and it helps in a couple of ways. So firstly, it improves the blood supply to your muscles and it decreases the workload of the heart. Now through doing this, you're decreasing the amount of work the heart has to put in to pump the blood because you're making less of it come back. So think about the plumbing in your house. The pipes are their normal size and you have a lovely water pressure. Now, if I were to double the size of your pipes but not do anything to the water pressure, obviously the water is going to come out quite slowly and not quite as fast. That's exactly what's happening with GTN. So it's opened up all the vessels in your body. So not a lot of the blood is necessarily coming back that was before. So you've decreased the pressure because the heart is now not pumping so hard to still get blood out. For you guys, the only administration for GTN is cardiac chest pain or discomfort. So you go along with aspirin. So aspirin, GTN and pain relief is the three that you tend to do. So don't worry too much about other indications when people start talking about them. This is just for cardiac chest pain or discomfort for you guys. Moving on. So, contraindications. We've got known hypersensitivity, a systolic blood pressure of less than 110. If they've had Viagra or Levitra in the last 24 hours. Now, the two other names for Viagra or Levitra, so sildenafil citrate and vardenafil, for Levitra, I've put up there as well. Most people won't necessarily know those ones, but it's more if you see them on the packet. They'll know if they're taking either Viagra or Levitra. So think of the two V's, so Viagra and Levitra. So 2 V's in the last 24 hours. If your patient just looks generally pale and has very moist skin, if their heart rate is over 150, if they've taken tadalafil or Cialis in the last 4 days, or the heart rate is less than 160. Now, my acronym I've used is KISS PHTH. All the capital letters and the ones highlighted in red are the ones that correspond to the contraindications. Like I said, if you have one that works for you, you use that acronym. This is just the one I've used to remember some things. Now let's go have a look through as to why some of them are contraindicated. Now, I don't want you to get hung up in the fact that there's, all this theory and stuff behind it. We're more going through this to give you an explanation as to why they're contraindicated, because it might help you to understand and might make it a little bit easier to remember. So going through from the top, hypersensitivity, obviously, if they've had it in the past, they haven't had a good reaction to it, they're not going to have it again. Generally, the most types of reactions that are associated with GTN is a significant drop in blood pressure. So they might have had about 160 systolic and you've given them half a tablet and they've dropped down to 90 systolic. That's obviously quite a significant drop, and that's usually the hypersensitivity reactions you'll see. Now that leads you into the blood pressure one next, a blood pressure of less than 110. Now the reason this is important, think back to the pipes. If they were only pumping at a certain pressure, now 110 is quite a low blood pressure for most of the patients you'll see. So I'm talking about, if they're maybe a little bit unhealthy, if they're obese, if they're elderly, those types of things. A blood pressure of 110 you're more likely to see in younger, fitter people. Mostly, this is a gross generalisation, but that's usually where you see it. So going back to the pressure, if they're pumping at 110 and you now open up the pipes because GTN dilates the blood vessels, so you now have opened up the pipes, all of a sudden that 110 pressure is not a heck of a lot anymore. So you might see quite a significant drop in blood pressure, which is not what you want. The last thing you want with these patients is now to have to lie them down and put their feet up because you've dropped their blood pressure. So 110 is dead on. Anything less than 110 or less, do not give it to them. So just think back to the pipes again. If you only had a certain amount of pressure and you now double the size of the pipes, that pressure is no longer going to be there anymore. And we all need a good blood pressure to stay alive. Now Viagra, Levitra and Cialis, so they tend to be erectile dysfunction medications. They are not isolated to men. They are also for women. Women also take them. So don't skip these questions when you're assessing females because they also take these tablets. I've had a lovely 80-year-old lady who I was unable to give GTN to because she had some Viagra last night. So, like I said, don't make the mistakes, both males and females. Now, the reason it is contraindicated for these two, most of the erectile dysfunction medications cause vasodilation. The reason is they let blood flow go to the important parts, which you want for some playtime. However, when you're going to give them GTN for chest pain reasons and they already have these drugs on board, you might get into a little bit of trouble. They've already got a vasodilator, so a pipe opening drug in their system, and you've now given them another one. So we don't want to open it twice as much. Again, it's all about blood pressure and maintaining their blood pressure. Pale grey and moist skin, that's kind of in there for when you think about your patient. If your patient looks terribly sick and they're they're just sweating bullets, they look terrible, they actually look great. They're probably not going to have a heck of a lot of blood pressure anyway, and that usually tends to be an indication that they're quite sick. And that's why they've put it in there. They've put it in there for you guys as something to be aware of. When they look that terribly sick, don't give it. Because if you don't have a lot of training in the area, there might be something else going on that would contraindicate GTN. But rather than bombard you with heaps and heaps of contraindications, all they're saying is if your patient is pale with a grey and moist skin, don't give it to them. Now the last couple, so when you're looking at your heart rates, so heart rate of greater than 150 and greater than 160. So again, this ties in with the pressure. If you are pumping along at a normal heart rate with a normal pressure, all your muscles, all your organs and everything get the blood. Now if you're pumping along at 150 plus, there's not a lot of filling time that happens in the heart. So for a beat to happen, just before a beat happens, the heart fills up with blood. So while the heart's resting in between beats, all the blood fills into the chambers, it beats, everything gets pumped out. When your heart rate goes very fast, this filling time decreases because the heart isn't still for very long. So the amount of blood that fills into the chambers gets less and less the faster the heart goes. Now, as you can imagine, think of blood going in. If it normally fills as it should and it pumps out, everything gets the blood it needs and the heart keeps pumping normally. When less and less blood goes into the heart, it means less and less are going out. So your muscles and your organs aren't getting the blood they need. That's just under normal circumstances. If you now open up their pipes and you make even less blood come back to the heart, there's not a lot of filling time, as I said anyway, as when it goes faster, so it means even less blood is going out. So you're potentially going to make things a hell of a lot worse by giving them GTN, because not only are you taking away the pressure, the heart's already not pumping at full capacity, and now you're taking away the little bit that it was pumping. And on the other end of the spectrum, when it's now less than 60, again the heart, so go back to a normal heart. So while the heart is resting, all the chambers fill up and it pushes blood out. Now you've put GTN into their body, so the pipes have opened up. So less blood is coming back. This more becomes a problem that, yes, less blood is coming out, so potentially you are pumping less. At the same time, one of the side effects of GTN is bradycardia, which is slow heart rate. So not only, again, are you affecting the blood coming in and pumping out, but you're also risking a side effect of GTN, which is to make the heart rate even slower. So that's why the two heart rates of the spectrum is a problem. So greater than 150 or less than 60 are two very specific contraindications and two to be aware of. So no previous administration and elderly patients. They're fairly simple ones. So no previous administration is for patients just to be weary of dropping their blood pressure too much, because you don't know how they're going to react. We've got 2 doses you can give them, and the decision you make is based on whether they take GTN every day or not. So no previous administration is a precaution, so make sure you ask your questions to see if they take GTN or not. And if they don't, you always err on the side of caution with GTN. GTN is probably one of the most dangerous drugs you can give out, and therefore know this drug sheet very well so that you ensure you only give it at the right time. Second one being elderly patients. The elderly in general are considered as patients over 60. And the reason they are in here is because they are just more sensitive. Everything is more sensitive. So as they get older, the systems become less effective. So if you go and muck around with their body systems, so you go change their blood pressure, so you're mucking around the cardiovascular system, any rapid changes they might not be able to compensate for. So if you've dropped a 20-year-old's blood pressure, within 5 minutes they might bounce back and they'll be fine. If you drop little old Nana's blood pressure, she's going to struggle a bit to bounce back because everything just isn't what it used to be. So with elderly patients, always, always, always be cautious. You can always give them more GTN in 5 or 10 minutes, but you can't take it back out. So always take your time, especially with the oldies. And that's really where all drugs are concerned. You make sure it's the right drug, and you take into consideration that they're probably going to be a bit more sensitive to it than your average 20-year-old. Alright, side effects of GTN. Hypotension, tachycardia, skin flushing, which happens occasionally, and bradycardia, which is uncommon but still a side effect. So the acronym I have for this is HATS bring headaches. So again, all the numbers, all the letters are highlighted for you, and the last one, headaches, is obviously the last part of the acronym. So going through why they are side effects. So the side effects all relate to the actions of GTN. Firstly, hypotension. You've opened up the pipes. It might be too much for that particular person. It's now caused them to be hypotensive, which is not what you want. Hypotension is the most common and also the most significant side effect of GTN. Now, because you're dilating the pipes, dilating the capillaries can occasionally cause skin flushing. So it just means it's blood very close to the skin surface that weren't there before you gave them GTN. So you might see, they just look quite red and flushed. At the same token, dilating the blood vessels in the brain is going to cause more blood in the brain, increasing the pressure. Remember, your brain is an enclosed space, so anything that mucks around the pressure, being it less or making the pressure more, is going to have an effect. So that's why we can potentially see headaches. When we move just to the last one of bradycardia, again, GTN does not act on the heart by a long shot, but it does have indirect changes to the person's so going through to the sympathetic going through to the sympathetic nervous system, and then their ability to compensate. So if they're already bradycardic, they can't necessarily compensate very well for a drop in blood pressure. You might see patients who are normally bradycardic, or if patients are beta blocked. So it means if beta blocker is a tablet that stops their heart beating above a certain rate. So they might be normally bradycardic anyway, but still be very wary and still be aware that GTN can indirectly cause them to have excess bradycardia on top of what they normally have. Right, let's move on to ipratropium bromide, or Atrovent, which sounds a heck of a lot easier and better. So indications: severe asthma, nice and simple. Contraindications is known hypersensitivity to atropine or its derivatives. Now, atropine is a fairly safe drug, and it's used in conjunction with your salbutamol. And you usually give it for in patients having, wheezing as part of their asthma. And how it works is it blocks bronchoconstriction from happening. So your brain, according to Brainwind, has an asthmatic reaction, thinks, yep, I need to constrict everything, this is the way to go. And as we all know, that's not the way to go, and that's making it worse. But by blocking its action, it's allowing dilation of the airways. So Atrovent goes against what the brain is doing, in essence, to save the patient. Now, when it comes to hypersensitivity to atropine or its derivatives, patients will know it well, because they would have had a fairly severe reaction to it in the past. So this is where your questioning comes in quite importantly when it comes to their allergies, etc. And I always ask patients as well when it comes to Atrovent, just have you had Atrovent or ipratropium bromide before, and are you allergic or sensitive to atropine? Because they will know if it's the case. Pardon me. Precautions: glaucoma, and avoid contact with the eyes. Now, these two are easy to remember because one causes the other. Now, glaucoma as a disease involves a raised pressure in the eyeball. Now, what happens with Atrovent is it causes the pupils to dilate. Now, this can interfere with the fluid that normally drains out of the eyeball and can cause an increased pressure. So if the person already has glaucoma, if you then put Atrovent in the mask, but you don't put it properly on their face and their eyes get exposed, this might make their condition a fair amount worse. Atrovent can also cause eye irritation in any patient, so just avoid contact with the eyes as a general rule. But if your neb mask is sitting properly, the likelihood of the mist from the neb mask reaching their eyes is less. So be careful, especially with glaucoma patients, and then avoid eye contact, as you can make the glaucoma worse, but you can also cause irritation for normal people. Moving on to methoxy. Alright, so methoxy. Indications: pre-hospital pain relief. Very easy. We all know the green whistle. We've given it multiple times, and it is one of the fantastic ones in the kit that I love. It is very easy to administer and tends to have really good effects for patients. Now, it used to be used as an anaesthetic in the older days, and now they found that at a low concentration, it's capable of providing really good pain relief. Right. Contraindications. Pre-existing kidney disease. Patients taking tetracycline antibiotics. Personal or family history of malignant hypothermia and muscular dystrophy. Now, the reasons for these are quite extensive behind them, so we'll go through them so you understand why they are contraindicated. Just before I do acronym. Oh, and it's using 6 meals in 24 hours. Apologies. So acronym for it is triple P me. So PPP me. Again, letters and stuff are highlighted for you. If you have your own acronym that works for you, use it. That's the one that's in my CPG, so if it works, you can use it with yours as well. So penthrine as a drug. The reason it is got so many precautions, especially involving the kidneys, is because that is the main way that the body actually gets rid of penthrine. The kidneys are responsible for getting rid of it. Now, the metabolized product can cause damage to the kidneys. So if the metabolized product refers to the patient taking the drug, and now the body's used the drug and they're trying to get rid of it. So that's the metabolized product. So patients that already have kidney trouble, so they've already got kidney failure, or they only have one kidney, or they've got some sort of problems with the kidney, their kidney is already working hard, and now you're putting something in their body that's making them work even harder. So that is why it has all these things to do with kidneys. So firstly, pre-existing kidney disease, big no-no. Their kidneys are already working. You cannot make it work harder because you're risking more damage. When it comes to the tetracycline antibiotics, how they work again has quite a significant toll on the kidneys. So they are known to cause transient injuries to the kidneys. So that means injuries that passes. It's not necessarily permanent, but while they're on this particular antibiotic, they might cause some injuries to the kidneys. Therefore, don't give them methoxyflurane because methoxy relies on the kidneys being able to excrete it. And if the kidneys aren't, it can damage them. Now, if these antibiotics have been completed or ceased, then penthrine can only be given after 24 hours. So if they only ceased it this morning and it's now in the afternoon, you can't give it to them. You have to wait 24 hours. Now, since methoxy, as I've said before, can cause injury to the kidneys, they've recommended that no more than 6 mils be given in 24 hours. So that's your last contraindication there. Because again, this is what the drug companies reckon is the maximum dose for preventing any kidney damage. Now, when it comes to the malignant hypothermia, so this is a condition when certain patients have gone in for operations and stuff, they've gone under general anesthetic and their body has just not liked this general anesthetic and they get diagnosed with a condition called malignant hypothermia. And this is a potential life-threatening, rapid and uncontrolled rise in body temperature, abnormal breathing and heart rate. So it's quite a reaction that you see in these patients, and these patients will usually know very well about it, and they will also know if it has been in the family. So that is why it is very important to ask, because they cannot tolerate certain anesthetic medications, and penthrine in particular has been one of the ones that's been associated with malignant hypothermia. It is a hereditary condition, so if there's a family history of it, don't give it. So if mum has it, don't give it to the kid. Now, the last one we haven't talked about there is muscular dystrophy. Now, muscular dystrophy, these patients, when the muscles break down and when the muscles start to waste, again, it gets excreted through the kidneys. So the kidneys are already working quite hard with these patients. And patients with muscular dystrophy particularly have been reported to suffer life-threatening complications during general anesthetics. So this is where methoxy ties in. And it's the main part where it ties in because methoxy used to be a general anesthetic. So one of the biggest complications is life-threatening rhabdomyolysis. Rhabdomyolysis is the breaking down where the body breaks down the muscle and just completely, not just integrates it, but starts to break it down. And one of the processes is to put it through the kidneys. So again, you see how it all ties back in. Methoxy needs to be excreted through the kidneys, and if they're already suffering muscular dystrophy, their kidneys are already working really hard. And you are going to make it significantly worse if you give this to them. And we've gone through the rest of them on training night, so just write them down if there's anything I say that isn't clear, and we'll go through it all on training night. Alright, precautions. Pre-eclampsia, the patient must hold it in their own hand, so you are not allowed to hold it through their face. They must hold it in their own hand. So if they become unconscious, if they've had too much of it, it'll fall from their face and they'll regain consciousness quite quickly. And lastly, the patient must be supervised at all times. My acronym for it, PMS. Again, I've highlighted the letters in red for you guys so you can see where it is. The last two are quite self-explanatory. So you know they must hold it in their hand and you must be looking after them all the time. That's kind of common sense. Now, preeclampsia tends to be one you see with pregnant ladies, and I don't know if any one of you who's had kids had any preeclampsia. It is a very serious condition. It is associated with increasing in blood pressure, especially, and the reason it is a precaution for methoxy is there's a potential for renal damage. With these patients that have preeclampsia, their kidneys are already at risk of damage because of the higher blood pressure and the higher amounts of protein in their blood. So because their kidneys are already working hard, you're potentially risking more damage by giving them methoxy. At the same token, though, we cannot give patients opioids in late second stage labour, so you won't be able to give them fentanyl. So methoxy is your only pain relief. Now, it is only listed as a precaution. This is only precautionary. So like I said before, a precaution doesn't mean a contraindication. It is just something to be wary of. So if they say to you, for example, my kidneys have suffered significantly because of preeclampsia and the doctor says my kidney function is down, maybe consider not giving it. But if they just say they have preeclampsia and nothing else, it is a precaution, so you can still give it if they need pain relief. Alright, let's run through the side effects of methoxy. So drowsiness, greater than 6 mL in 24 hours may lead to kidney damage, and a decrease in blood pressure and bradycardia, which is rare. Alright, going through them, drowsiness, that one's kind of common sense. Remember, it is pain relief at low concentration, but it used to be a general anaesthetic, so of course they're going to get a little bit drowsy. Greater than 6 mL in 24 hours we've talked about before, so that is what they recommend as a safe dose to prevent kidney damage. Any more may definitely lead to some damage. Going through a decrease in blood pressure and bradycardia, these are rare reactions and you do not see them much. Again, this is more just to do with the general anaesthetic effect, which is why they're dropping their blood pressure. And low blood pressure, your brain might interpret that as, okay, well, I don't need a heck of blood pressure, so I can just pump slower, and hence you see the bradycardia. But both of these are fairly rare, so you shouldn't see them very often at all. Alright, heading through to oxygen. Indications: cardiac arrest or resus, treatment of hypoxia or hypoxemia, so when you have a SATS reading of less than 94, anaphylaxis or shock, major head injury or traumas, severe sepsis, seizures, carbon monoxide poisoning, and decompression illness. Now, the acronym I've used is CHASMS CD, so it's kind of like a CHASM just with a double S and CD. I don't know, somehow that makes sense in my head. So if it works for you guys, great. Otherwise, you've got your own one. Like I said, just keep using that one. Now, oxygen, all these ones are considered beneficial and to help the patient to become stable. Cardiac arrest or resus and treatment of hypoxia is kind of common sense. You know, they're not breathing. They need a little bit of oxygen, which is why we help. It is shown to be beneficial in anaphylaxis, shock, major trauma, sepsis, seizures. Seizures in particular because they might not be breathing, their respiratory effort might be compromised because of the seizure activity. Carbon monoxide poisoning is an especially important one which you just need to have a quick talk about, because when you put the SATS probe on a person with carbon monoxide poisoning, it might read as 100%. Because the hemoglobin in your blood can either bind to the carbon monoxide or to oxygen, and carbon monoxide has a stronger affinity onto the hemoglobin, so oxygen will get pushed out of the way if there's carbon monoxide. And as far as the SATS probe is concerned, as long as there's something bound to the hemoglobin, it's going to show you a good reading. So it might show 100% for a patient with carbon monoxide poisoning, and we obviously can't rely on that, so that's why they have to be given oxygen. And decompression illness, without going into too much specifics, just because of the presentation of the patient and the illness that is going on in their body, it is beneficial for them to have oxygen. Alright, contraindications. Nil of significance. So if something doesn't meet any of those indications, you don't give it. Precautions. Be aware of fire and explosive hazards. This is more when you've got the oxygen cylinder and stuff with you. And again, like most of you know, that will be pretty common sense. Alright, side effects of oxygen. Drying out of the mucous membranes in the upper airway. I'm sure most of you would have seen this anyway. You know, you put the nasal prongs in someone and they complain of a dry nose. Halfway to Aubrey, it's just because you've got all this air running over and pure oxygen, which they don't normally get. so it's going to dry it out. Alright, salbutamol. We're nearly there, guys. Hang in there. So, indications. Breathing difficulty with a wheeze and or a history of asthma. Breathing difficulties with severe allergic reactions. No relief from the patient's own Ventolin administration. Breathing difficulty with smoke inhalation. And the acronym I've used is BNB, so with a double B at the start. So salbutamol specifically is indicated, like I said, for patients with wheezing and breathing difficulties. Now you see the wheezing because as asthma or anaphylaxis or whatever the reason for the bronchoconstrictions is kicked off, bronchoconstrictions happen so the airways are smaller. So you're still trying to push air in and out of a smaller airway, which is why you hear the wheeze. Now, if the patients have used their own puffers and it hasn't worked, again, this is when salbutamol is indicated. And at times it might just be because they didn't use their puffer normally. So this is why the puffer is in for you guys. If they use the puffer correctly, it is just as effective as putting a mask on, but some people do need coaching a little bit with it. You can also see bronchoconstriction when it comes to smoke inhalation, like we said there. Again, the lungs are irritated, bronchoconstriction occurs, so all the pipes in the lungs constrict, and now you're trying to push air in and out of there, and that's when you're seeing the wheezing. Going through the contraindications of it, so simple, kiddies less than 2. The reasoning for this is because children less than 2 have quite immature airways, and when you put salbutamol in, their airways are unlikely to respond to it because they are that immature. So they're not really going to benefit of it, and there's potential side effects that we don't want. So that's why kids are contraindicated for salbutamol. Precautions? Nothing. Nice and easy. Side effect, tachycardia and muscle tremor. They're two very simple side effects and two that you don't really have to worry about too much, but you can, the patient might be a little bit anxious about it, and so it might take a little bit of reassurance for them. So salbutamol acts directly on the nervous system, and it can cause stimulation of parts of the nervous system, which is why you see the muscle tremor and the tachycardia. So very simple, just because it acts directly on the nervous system too. Alright, paracetamol. Indications for paracetamol. Mild pain relief. As you all know, this really doesn't need explaining. You and I will take paracetamol. It is a safe as houses drug, providing you take it as indicated and you don't exceed what it does. It is important, though, to know that paracetamol should not be given to patients with cardiac chest pain. It's not indicated. These patients need gold standard chest pain relief, which is with nitrates. So it's not indicated to give paracetamol to patients with chest pain. So even if they say their chest pain is only 2 out of 10, which is considered mild, it's preferred to give them nitrates. All right, going through the contras. So hypersensitivity to paracetamol. Children less than 1 month old. Apologies, wrong order for you there. So total paracetamol intake exceeding 4 grams for adults or 60 milligrams a kilo for kids within 24 hours. Kiddies less than 1 month. And hypersensitivity to paracetamol. PATCH is my acronym for it. Now the reasons, some of these, let's go through a little bit of the reasons. So most of them are quite self-explanatory, especially when it comes to the total paracetamol intake. Paracetamol in very high doses or in overdoses can be very toxic to your liver, and that is why there are certain limits set to it, so i.e. 4 grams for adults or 60 milligrams a kilo for kids. And it is important that you take into account what they've taken and actually count up what they've had. Usually the maximum is about 6 tablets of paracetamol a day. It's usually not more unless they're specifically directed by their doctor. But as a general rule of thumb, no more than 6 tablets in a day. Doses very close to each other. The reason 4 hours is in there is because the drug hasn't really been allowed enough time to metabolize. So if they've had Panadol an hour before you get there and you give some more, you're potentially going to put them into a toxic level. So there might be too much in their bloodstream at one point, which is going to be toxic for the liver. So that's why less than 4 hours is not recommended. It takes 4 hours to get to a good therapeutic level, where when you take more, it's not going to go into toxic levels. When it comes to kids less than 1 month, all their systems are immature, so giving children less than 1 month paracetamol is going to potentially be toxic and damaging to them. Heading through to precautions of paracetamol. impaired liver or renal function is your only one. Now, as we talked about before, paracetamol, again, very similar to all the other ones, are metabolized by your liver and then excreted by your kidneys. Now, because paracetamol is can be very toxic to the liver in the wrong doses, that is why it is a precaution. So if the person's already suffering liver failure or they've had sections of their liver removed or something, be wary of that and potentially think about giving them a lower dose, because the liver's still got to metabolize it. So if there's any impairment in the function of their liver, you might just want to consider giving them a smaller dose. And again, the kidneys have got to get rid of it. So if there's any concern with how the kidneys are working, they might have trouble getting rid of it, which again can lead to toxicity in the liver. So that's why the 2 is not precautionary. So just think about your doses if the patient has liver or renal impairment. Side effects: hypersensitivity reactions, including severe skin rashes. Very rare, but as with any medication, you can have side effects. So that's potentially why you might see this with paracetamol. But again, like I said, it's generally overall a very safe drug. So not one you have to worry about too much. Alright, last drug. We're nearly there. Indications for ondansetron. Nausea and vomiting. Ondansetron is an antiemetic, and without boring you with a heck of a lot of things, it assists with nausea and vomiting. Now, it's very good for us because it's very easy to give, and it's also very beneficial for patients who are about to be transported via air ambulance. Contraindications: hypersensitivity to ondansetron. When the patient's taking apomorphine, so this is a specific treatment for Parkinson's. Long QT syndrome, which again the patient will know. If you ask someone, they don't know what it means, they don't have it. Chances are they don't. But long QT syndrome is just a heart condition where there's a bit of a delay in conduction of the electricity through the heart. So people will know if they have it. Most people will be unaware of it if they do have it, and then if you see any complications, that's outside of your scope, so you don't have to worry about having to learn more. Just ask it so that you can identify the patients who already know they have it. And last one is low potassium or magnesium levels. Again, these patients will know it because they will either be on infusions, on transfusions, or they'll be on supplements or something. So usually patients will know if they have low potassium or magnesium levels. My acronym for all this is HALL. Just HALL. Moving on to precautions. So patients with liver disease should not receive more than 8 milligrams per day. For these patients, it's purely again because ondansetron is being metabolized through the liver. So you don't want to give them anything that's going to make it any worse, and you also don't want to give them anything that is going to make that is going to cause toxic levels in their liver. So that's why be precautionary with them. 8 milligrams is our max to give anyway, but especially be wary for patients with liver disease. So if you need to consult for more for whatever reason, if they've got liver disease in their history, they shouldn't be getting more than 8 milligrams a day as it is. Alright, that takes you guys through it. So you need to know these drug charts off by heart. So indications, contraindications, precautions, they are very important. Like I said, the better you know your drug charts, the more reassured you are going to be at a job, and the happier you're going to be giving drugs because you know you can explain side effects when they come on and you know how this drug works. So for the test, you'll be required to know your indications, your contraindications, and your precautions. The reason this video hopefully would help you guys is just so now that you have a bit more of an understanding about how a drug works and why it causes the effects it does, it might be a bit easier to remember. So hopefully you've taken some notes, and hopefully this has helped you guys a little bit. This is the end of this one, so I might do a few more if you need any on the drugs. Otherwise, give us a call, either me or Reet, if you need anything. We're always there to help you guys through it, but unfortunately it is learning time for you and it's memorising time. I've sent you all a template that's got the open dot points for you, so you can practice writing out your drugs. There's more than one way to learn them, so write them out. If you do it 2 or 3 times a week, you'll know it very easily before the end of the month. If you're a visual learner, write it out, stick it on the back of the toilet door. If you look at it a lot, it'll help you remember it. There's lots and lots of different memory pathways, and if you need any help to learn things, if you're struggling to memorise it, give me a call. I can give you lots of different things to try, all tried and true methods. So hopefully we can get you guys the best way for you to learn. But Hopefully this helps you. If you need anything more, please let us know. We're always here to help you guys, and then look forward to training night. We're going to have a lot of fun. If you have any questions, make sure you jot them down and bring them to training, and we'll do our best to answer them all for you, or at minimum, find you some answers. Alright guys, have a lovely day. Bye!